Richard, Happy New
Mark,
Year.
how are you? Happy New Year.
Good, good. Well, we're at the first podcast of 2026.
Yep,
And so what I thought we do is take a retrospective view of 2025
sounds
and
good.
then for a few minutes and then go to 2026 predictions as it pertains to Airway. What are your thoughts?
I love it. I think that's great. And I think that a lot happened in 2025 and a lot will happen in 2026. It's very exciting.
Great, great. So I think that when we look at 2025, what I have noticed being in this space for as long as I've been is that it seems like we're hitting a tipping point regarding airway, say, airway education. Airway awareness has been around for a bit and kind of in a distorted way. We'll talk about it like mewing and bone crushing and things like that. We'll talk about that for 2026, like the social media aspect of
Right.
beauty and airway. But from the dental education point of view, as it pertains to airway focus, I do think that we've gotten to this point where the profession is, it's been paying attention to it, but that it's a tipping point, if you will. And as you know, that tipping point is that where you reach a critical mass to where the early adopters finally are able to get the other group in that technology curve involved or really talking about it. And then, of course, the laggards are at the tail end. But I think 2025 is that year, kind of like AI. I mean, AI has been kind of bubbling up. And so we're seeing this convergence of quote unquote new knowledge, even though we know it's not new knowledge. It goes back 100 years. But let's talk a little bit about dental education. I know when we were in the green room here, you were talking a little bit about a meeting coming up in April. And of course, we're having our Airway Mini Residency 3.0 in a couple of weeks.
Right.
And I think from my point of view, what's exciting is that there is enough belief and understanding that you're seeing these curriculums all over talking about it. So when I started back, whatever, 15 years ago, everything, the focus was on sleep, was sleep group solutions, how to make a widget, an oral appliance that's focusing on obstructive sleep apnea. And so that was the focus. And then when I started putting these courses together with Barry, we're really focused on really breathing that affected sleep.
Yes.
Now, and from that came that term airway,
Right.
where, we were looking at what is the airway, and we define it as, the facial skeleton, as Don Enloe defined airway as a keystone for the face, and kind of got
Right.
into all that.
Sure. Sure.
And yet with all that, it's like, what does the dentist do? So certainly when you're talking about obstructive sleep apnea,
Hmm.
a dentist could take a weekend course. They could even get certified by learning more about sleep medicine, knowing they can't really treat it without a physician, where they can make a widget. So they can generate an income from providing some gold standard
Right.
oral appliance, of which there are so many different designs, and people
Oh
would
yeah.
argue about the different designs. And is it vertical? Can you add, and so those were the discussions. Then it started moving more towards airway. And what's exciting there is that we understand that it does fall well within the domain of dentistry, but the difficult part is how really do you scale those concepts? And so what's exploded in, I think, 2025 is really the understanding and visibility of St. Mark's skeletal expanders. And they've been
Absolutely.
around for a while.
Yeah.
I've been using them for several years, but it wasn't, of course, Juan Moon talked about it with the MSC some years ago, but it wasn't in the context of airway per se. So now it is. So now you can take a weekend course, right? And you go in
Right.
there and you learn how to do a marketing, but is that the only tool that you have? And our concern, as you know, in the mini residencies, that we remain agnostic about the intervention, that you really immerse yourself in the diagnosis, looking at structure, function, behavior. And so 2025 is exciting in that we've seen these courses explode and these thought leaders who are teaching these courses. And I think you were telling me in the green room about a sleep physician that is putting together, ironically, as a sleep physician, a group of dentists to come in
Right.
and deal with that. But I could just say that it still is not airway per se, though you can give it that term,
Right.
because in dealing with airway, you really need to deal with, structure, function, and breathing behavior. And sleep physicians, by and large, really ignore the breathing behavior part, and they do understand the neurology, but myofunctional therapy is it's kind of getting some attention. So 2025 for me has been exciting in that we've been getting this ramped up. I know we'll talk about 2026. What are your thoughts?
Yeah, I was going to say that first of all, the sleep dentistry, if you want to, I think that's what people call it, or has been around for a long time. And I remember back at UCLA talking to my students about the importance of recognizing all the anatomical and signs and symptoms of OSA, and being really mindful of that. I was working with a prosthodontist on a case, and we were talking about what kind of appliance to give the patient, which will not hurt their occlusion, and this and that. And that goes back probably 15 years or more. And I remember looking at the myriad of choices for all these appliances. And so the mindset was just so focused on widgets. And I think we were really not even in our lane for the most part. We didn't really understand the entire spectrum of airway at all until you came along, quite frankly. And people that have gone through your training understand it at such a different level. I'm not going to say higher level, but let's just say a more appropriate global level, and incorporating into that understanding, basing decisions on true markers of improvement and not just delivery of things. And then later, so this went on for a long time, and being very interested in airway, I wanted to pursue it. And the only other than what you had to offer, which was, I think, obviously incredible and probably the finest level. It just was a lot of courses on sleep this, sleep that, and devices, and boy, they go on to quite lengths to get people to get interested in this. And then recently, though, it's all about expansion. It's all about MARPEs, and so I talked to a colleague of mine recently that went to a MARPE course, and I said, well, why'd you take the course? Well, because I want to learn how to expand people. And I go, but why? Well, if they're narrow. And I go, but why? Well, they and kind of stumbling, and I was thinking, like, what are the other people in the course? What were their reasons for attending these courses? Oh, they were a mixture of orthodontists and general dentists, and they all wanted to learn how to expand people. I go, but why are they expanding? And under what context? What was the reason for even ending up there? And once again, Mark, I think even though you highlighted sort of a favorable recognition, and I'm sure you can explain that more, I still see it as a transfer from one type of widget to another kind of a widget still, in my opinion, for what I'm
Yes.
seeing. And
Yes.
these courses are really popular, and they're expensive. And so people are diving into these things without really having the perspective that I think you can get from the Airway course. And I wanted to throw that in there because this is it's great because it seems to be moving more away from sleep per se and moving more into maybe the dentist's wheelhouse. But at the same time, I'm not sure that the perspective is being really laid out. That was not even mentioned once in the course that my friend took. She spent, it was a 1 day or 2 days. It may have been 2 days, or I don't remember, but not once was this being mentioned. So, or any point of reference on where this would fit into the airway minded dental perspective. So,
Yeah, well said. What I liked about what you said, that I think really describes the situation pretty accurately, is it was a transition from one widget to another, right?
right.
One from management,
Yeah.
and then unwittingly one towards more a cure. Okay, I say unwitting because they don't really understand,
Well, I think
what
it's
that really
correct.
means as a
It is
percent
unwitting. You're
anyway,
right.
right?
Yeah.
Yeah. So what do you do with the mandible, right? So
right.
these courses are somewhat like that, and I think that really speaks to just healthcare in general. Most
Mhm.
dentists really understand that when they're taking a course, they have to ask the question, well, how can I really translate this into my clinical practice as a service to offer patients? And it's pretty straightforward. If it's an intervention, you
Mhm.
can increase your productivity, if you will, by learning about something that you can do that is that you could charge for.
Right.
And I think what that does is it does create a bit of a mechanical thought process. And I think it's the same really with medicine, where you're looking at elective services like bariatric
Mhm.
surgeries and facelifts and Botox and doing those types of things that are discretionary, that are intervention driven. So this does fall into it. And I think that that's what concerns me, is that we continue to practice in a way that does not emphasize the DDS part of it, the doctor part of it, and more kind of the mechanical part of it. And so I think it is a higher bar to really understand what airway really is, of which an intervention is. There's a whole toolbox, if you will, right? Once you understand, but it's rarely just an intervention. And that's what these courses are about. It's about that part of it. But how do you apply it?
Well,
What do
and
you talk to your patient and say, hey, you've got a palatal width of 33, let me make it wider? Like, why?
right. Right. And then I'm asking, well, what's the reason that they give for doing all this? And they're like, well, it broadens the smile, and it makes the maxilla look better. And then they just take the teeth after things have been expanded skeletally, and they just tip them into the mandible and tip the teeth out a little bit. And I'm like, wait a minute. So all this work is being done to kind of address part of the concern, but not really the reason for me to even want to get into utilizing some kind of expansion would be based off the medical model and what are the symptoms and what are the appropriate signs that we would want to look at and what are we treating to, what's our endpoint and why would we intervene and when, and I how in the I just it's kind of like trying to teach a dental student how to do a class 2 amalgam or composite preparation without having them understand the reason why they're doing it at all. Like, this is because of caries. Well, what kind of caries and how does caries occur and where does it occur and what might you find? But just to focus on a plastic tooth that has no decay in it and make a shape, that's fine. That's part of the solution, no doubt about it. And that's a skill set you need to master. But to not understand the entire perspective really, I think, kind of misses the mark. I
Yeah,
don't want to be
yeah.
too
And
critical because I haven't attended, and I'm sure that there are lead-in courses perhaps that teach this, but I haven't personally heard anything concrete that looks like people are putting this in the perspective of of a carious lesion, the diagnosis of that, all the way to the final preparation and restoration of the class 2, that entire spectrum, they're just looking at, let's show you how to make a beautiful prep and fill the hole. And to me, that misses it. I know it's a simple analogy, but it resonates with me, because it's a lot of what I do is I teach students and dentists how to do a nice shape in a tooth sometimes. That's part of what we do in our teaching center. So I thought that could lend some perspective for a lot of people.
Yeah, I think let's go back to the why. And now you go back on Monday, you learn how to expand. Who do you expand? What's the reason? And then
Right.
all of a sudden, you start seeing everyone is narrow, right? So how are they measuring it? It's are they using McNamara's 37 to 39 millimeters, or is it? And as you know, we don't expand to a number. We look at root cause and airflow limitation. That's the reason why you do it. And when you
And we
start
measure the improvement.
right,
We look very carefully at what happens.
and the
So
medical metrics,
absolutely, which
and
is
and
so
so when you start
solid.
to,
It's such a solid approach, Mark. And I
yeah,
just uh, you know it, gosh, it's so important for us in dentistry, and we're so treatment driven, we're so surgically driven. We need to step back a little bit and say, okay, what is the outcome of that intervention? It for
so
example,
yeah,
if somebody had a notch on the gum line, you go, oh, there's a notch on the gum line, let's put a filling in there. And the patient had the symptoms of sensitivity, and then you put a filling in there, and the sensitivity goes away for a while, then it comes back, and then the filling falls out. The dentist just goes, oh, we'll just do better bonding this time or something. And
yeah,
nobody understands even why it even occurred to begin with. We have some theories, and you go back to Grippo in the 19th,
right,
long time ago,
toothbrush, and
looking at
yeah,
all of the
right,
erosion and occlusion and all these other things that can abrasion that can influence it, but actually they they don't even address why that even happens. So the thing I love about this deep dive into airway for me has been, it's what we thought was the why is not the why. There's a layer behind that, and I think that is an enlightening, incredible experience to actually find out what's happening, the rest of the story, what's happening behind the why that we think is the end all be all diagnosis. There's something even more revealing beyond that.
yeah. And I think why that's important is materially changes the way you talk to the patient, right? So
Absolutely.
instead of this, as Philippe Pujol wrote about many years ago, talks about tangible versus intangible benefits or outcomes.
Mm-hmm.
So, an intangible is a lot of what we providers think is what the patient needs. It's not really tangible to the patient. So, an intermolar width of 38 versus 40 is not really tangible to the patient. Now, you can convince them that it is, but what is tangible is better sleep or better breathing, right? So
Absolutely.
that's the surrogate marker, phenotype marker, if you will, that leads us to them being well. And that's what we talk about. And so if we really take the 40,000-foot view, as you know, and we look at the top 10 causes of death in the world, comparing industrialized versus developing countries, you find that the 20 million out of the 30 million people that died around the world in the year 2000 in industrialized countries, almost 90% of them died from reasons that were extremely rare 500 years before. And in 2016, that number is actually accelerated. Whereas in developing countries, they're still dying of infection and trauma, birth, parasitic, parasites, and things like that. And they're not dying from the metabolic diseases, the cardiovascular diseases, the neurocognitive diseases, which is we're dying in the West in higher numbers from those causes.
Right.
We're not now dying from infection very often or
Right.
from birth. So we really solved a lot of the problems, but it's mind blowing when you start thinking about all these other things that everyone already knows about. the increased risk and incidence of autism in children, and ADD, ADHD, obesity, type 2 diabetes. We just keep on managing in medicine and keep on saying, well, let's, okay, lifestyle change, but let's take some glucophage. And then eventually you get into GLP-1. So the thinking even in medicine is let's just manage a reality instead of saying, well, why is this happening? What can we do? And I think what makes airway focused healthcare meaningful to the patient, to the public's health, is that we really are getting to root cause. We're really understanding that how we breathe is material to that third of our life that nature has invested in us in this state called sleep. So a Starbucks and an energy drink, although or a creatine supplement during the day, may be some kind of management from the reality that your sleep quality or sleep quantity is not where it needs to be well. Well, we can manage it through medications or things like that. So I think
Right.
with airway, when you start understanding it, let's just go back to the study we reviewed, I don't know, 4 episodes ago, that multi-center study where we
Right.
had the surgeons, the
Looking at the
ENT,
children. Yeah.
pulmonologists, the pediatricians, the psychologists looking at over 12,000 kids looking at adolescent brain development, that what they found was that the volume of the airway was material to the function of the brain. There now we're starting to talk about airway. So you start talking to the parent differently than about your kid needs expansion. You start talking about really the future of that child and the path they're going to take, where instead of needing a tutor or Adderall or Ritalin to deal with those quote unquote behaviors, let's really find out why. Let's dig in deep. And if it results in an intervention that includes an expander because you're widening the nasal fossa on the angle of the liminal valve and less having to do with the palatal width, and it makes a difference, and you measure it, then now we're talking.
Right.
So I think we'll transition into 2026, right? So we look back at 2025. What we talked about is everyone's now coming to the the watering hole, if you will. And now what we want to do is talk about why. In 2026, I think people will start looking at it, and really requires medicine and dentistry to come together, right? And I'm going to say it has to go beyond just sleep. So there are these courses that you have sleep physicians that are giving them, and still they're looking at getting referrals from the dentist, right? But they're still talking about sleep. They are ignoring the breathing part, although some of them are starting to recognize it. And so we have to be very careful in really understanding the structural deficits that are defined by the craniofacial phenotypes that we get into in the airway mini residency. And even in this multi-centered study by very credentialed professionals at Harvard and John Hopkins and et cetera, I still will argue that although they've come to the conclusion of what we've been talking about for 15 years regarding airway, and it's not the first study, it's just the first really big study.
Right.
It's really not about the volume of the airway that is really the issue, although it is an indirect measurement. And they used MRI,
Right.
right? They're looking at soft tissue
Right.
versus the facial skeleton, and we could talk all about that. It's really the constriction in that, the kink in the hose, that's the real big issue. So even in that very large study, some of the threats to the internal validity, in my opinion, is they're still not understanding the airflow,
Would
right?
you, yeah,
It's
would you actually, what they did was they looked at structure, not in any dynamic way. It was a static image of
yeah.
the structure. And they made a correlation, which was very powerful, but they didn't look at function. They didn't look at behavior, correct?
Yeah, no, that's exactly correct. And when I sent that to Ron Harper, who's probably written more about obstructive sleep apnea and the effect of brain
From
effect.
UCLA, the anatomist from UCLA.
Yeah, at UCLA Brain Research Institute,
Right.
he even said, you've got to write a piece in the New York Times. This is seminal. I had invited him to speak. Gosh, it's got to be almost 15 years ago at one of the many residencies as a panel. And he went into it with the idea that it was really neurology. Now, really understanding that size does matter, but it's more configuration. So it's exciting that we're now moving towards recognizing that the phenotype does have a material effect. And bottom line, that's what that study was looking at, is that phenotype marker does have an effect, but it's more complicated. And these are the things that aren't covered in these weekend courses. So therefore, you can't really intelligently engage the patient in a meaningful way if you don't even understand it yourself.
Yeah, and
It's
I
still
think that
mechanical.
one of the dangers of a structural only perspective is you can miss people, you can miss situations, and I think that happens far too often. I've watched lecturers that want to pay. It's they want to include airway in their overall presentation of like a full mouth rehabilitation, and they'll throw up maybe a CBCT and with a measurement on it and see no airway problems, or maybe just look at one HRPO and look at the RDI index and see that it's low and see no airway issues. And I'm like, oh no, they're missing so much by having that perspective. But these are big, well-known people from the podium that are out there trying to influence others. And as an educator, I'm thinking back to someone like Dr. Richard V. Tucker, who I remember, this incredible dentist came up, put his arm around me at one time at a meeting at the Operative Academy in Chicago, and he says, Richard, I'm really proud of you for going into education. And he goes, but I want you to remember something. And he goes, I said, yeah, what's that, Dr. Tucker? And he goes, you don't know what you don't know. And you need to be careful, because what you say is going to influence many, many more people than the number of patients you could treat yourself. And I'm like, wow, very sobering and very helpful information. So having a little bit of humility and
Yes.
willingness to say, gosh, I don't know, is so important in this whole process, Mark. And
Yeah, no question, Rich. I mean,
yeah, so
the educator has this huge responsibility,
right,
and at least acknowledging the known unknowns and the unknown unknowns. That concept, as I always say, no matter how competent you are in any specific procedure, we always go into a procedure with a certain level of uncertainty. And we talk to our patients in the form of informed consent, right? The risks and versus the benefits. And our job is in becoming more competent is that we lower that uncertainty, but we never eliminate it.
right. I
And
mean, that's
so,
stochastic medicine. I mean, that's the stochastic arts, which dentistry has never really admitted that we are anything other than technical skills development will equals success. And one of the most sobering things about learning more about airway is that it doesn't work that way. It is a very, very different model, and it's something perhaps initially kind of uncomfortable for a lot of dentists that kind of look at problems as more mechanical in nature and don't look at the variability and the uncertainty.
right. In dentistry, right, we're trained to use a burr to tell us the depth of a preparation, or a probe to tell us the depth of a sulcus. What is um, low risk, high risk, right? And we've had traditionally this appealing visual mechanical way that gives us a sense of confidence that we're doing well by the patient. And now what we're starting to understand is there's this whole other layer that we've completely missed, like talking about biotype. And it's very easy to dismiss what you don't know because everyone's looking at the end stage diagnosis of obstructive sleep apnea. I mean, even within sleep medicine circles, even most physicians and pulmonologists, I will say, and I've talked to so many,
Hmm.
don't really acknowledge they're in the same place that a lot of dentists are as well. They don't acknowledge the problems in measuring flow limitation. They don't go through, and you know why? It's again, it's the bean counter, the practice administrator, the business model of that practice that says, look, Medicare is not going to pay for it, so let's just focus on what they will pay for. And let's use 1B scoring, which obviously misses a large swath of the population. Of course, these are things that we talk about in the many residency. In fact, I'm finishing up today final edits for the chapter 33 that's going into the Newman Carranza 15th edition textbook on this topic. And we actually have clinical cases showing the difference, first of all, the difference between obstructive sleep apnea, upper air resistance syndrome, as it pertains to inflammatory markers globally that crosstalk with local inflammatory markers without getting into that. But then also providing direction to the reader about understanding the difference between physiologically between a 3% oxygen desaturation and 4% oxygen desaturation. And that little fact alone will get in the way of you being able to properly treat a large swath of the patients that you look at a high resolution pulse oximeter screening that says, oh, they don't have the problem because you don't know how to read the report.
Right.
You know, you're looking at just an apnea hypopnea index, which is the standard in sleep medicine, but that still way underestimates flow limitation. These are things, of course, that we talk about. And
Absolutely.
so I think that's, that's part of the problem. In 2026, I think we will see more physicians jumping in and collaborating with dentists. And my hope is that the dental professional really starts correlating what we do as a core, like implant planning and full mouth rehabilitations and
Right.
establishing good occlusion and condylar position based on an airway focus, right?
Yep.
That's really driven by the medical indications. So it's kind
I,
of a backwards way of thinking of the problem. And
yeah,
I'm going to be hopeful to say, especially with you and I working hard on this, that we will start really bringing people to this understanding. And there are already a lot of early adopters that get this.
yes. And I was, it's amazing that, if I can just go back a little bit,
Please,
that just to think that you're authoring a chapter in a book that is known worldwide as being the ultimate guide to periodontal, the entire profession, especially a periodontist, on
it's the
airway.
most read textbook
Yeah.
on parallel all over
And
the
there's a
world.
chapter now on airway and its implications and with respect to perio. It's mind-boggling. That's going to be coming out hopefully in 2026, right?
Yes.
And then the other book, which you are the editor and author of, the
Airway focused
book on
dentistry.
airway-focused dentistry, is
Looking
going to.
beyond gums, teeth, and joints. Yes.
Now, when that hits, hopefully again in 2026, I know these things take time. Textbooks are, I've written chapters, and let me tell you, it is a long, grueling
Oh,
process. It's
stressful.
brutal. It's absolutely brutal. But once that gets out there, that is super exciting because now the people that have been sitting on the fence or don't even understand it at all are gonna that bother to read the book, and hopefully that will happen in great numbers. They're going to be clamoring for, wait a minute, I can't learn. You can't you can't learn to become a black belt in karate by reading a book.
Right.
You need mentorship. You need to understand that portal that you go through when you actually see the patient with mentorship and guidance and whatever. It's a completely different experience. So the book is going to create an enormous demand for the kinds of things that exactly what you know, and that is that people need to sit down with colleagues, with mentors, ask questions, see the cases, be able to even argue a different point, for example, in a free flowing sort of educational environment in order to achieve competency and the next level for them to be competent enough and confident enough to actually start treating patients in their practice. But
Yeah,
that is going to be, I can't wait for that day. That's going to be a
yeah.
huge
Yeah, well, thanks for
shift.
mentioning
You
that,
want to talk about
Rich.
shifts or pivots? That's going to be the probably in my 40 years. That'll be, in my opinion, maybe I'm just so focused on it now, but I think that will be the greatest pivotal change in dentistry that we've seen in probably my entire 40 years, maybe with the exception of osseointegration and CBCT or something. I mean, I'm kind of looking at a few things, but to have a text on a textbook on from A to Z on airway dentistry is mind
Well,
blowing.
it's necessary. Just to be clear, I've invited, I think it's like 14 authors from all the
Right,
different disciplines, but it's
right,
integrated into
right.
what we've been teaching in the mini residency for 15 years. And so it's
Yeah,
been a
yeah,
work in
exactly.
progress.
Sure.
It's like I've had so many people say, you've got to write a book, you've got to write, and where am I going to find that time, right? But
Exactly.
I finally said I've got to about maybe 4 years ago, and then I wrote to Elsevier and to my good friend Mike Newman,
Right.
who was editor-in-chief of the Journal of Evidence-Based Dental Practice I worked with for a long time at UCLA,
Brilliant guy.
very involved in Elsevier, and he said, here's what you need to get a contract. It was no small matter. You got to fill out this form. What's its impact? Who's going to be involved? And they were all over it. They're super excited about it. So you will be at the podium in a much riskier position to make statements when this textbook is out if you don't know it.
Absolutely.
Because
Absolutely.
and the thing is, because there's a digital version with it. It allows for dynamic change as there are rapid changes that we can add to it. Because we know the material could become stale. We just add to it. But
True.
the interesting thing that I'll mention to you, Rich, since you mentioned it, when Mike Newman, he had gone to maybe about 6 months ago at a big perio meeting
Hmm.
in Europe, and he came back and he said, "Hey, Mark, wow, airways everywhere. And I know you've been talking about it. I know you're writing this book on it. Would you mind writing or authoring the chapter that's that currently is in the 14th edition of the Carranza Newman Perio textbook?" And I said I'd be honored to. And I invited two very well-known periodontists to co-author with me. And when I looked at the previous chapter, I completely trashed it. Start all over. This is going to be a complete reboot of what had been previously written, which that chapter was just about sleep medicine focused on obstructive sleep apnea, and that we shouldn't really be involved, but we should recognize it. We really
Right.
should be referring, our patients that are fat and snoring to the sleep physician. I
Right.
said, no,
Right.
it's
No, but I understand from what I know, I you're going to get into the actual the mechanisms of that.
pathophysiology
Yeah,
and,
pathophysiology
and the
mechanisms and
inflammatory markers.
mind
It,
blowing. Yeah.
yeah, what I think is exciting, and the two Perio authors, George Mandelaris and Todd Shire, who are thought leaders in themselves.
Yeah.
And they're super excited. When I wrote like the first half of the manuscript, they go, "Oh, holy moly, this is huge."
Right.
And the argument that I had brought to them was, we need to redefine the role of the periodontist. It's got to look beyond frank disease, and we've got to look at inflammation much differently beyond just the local inflammatory response from periodontitis.
Hmm.
And that is part of an interdisciplinary team approach addressing the facial skeleton that's defined by the airway, breathing, and sleep. and the medical metrics and the understanding at the level of the cell and molecular biology, um, the role of all these inflammatory cytokines, the IL-6, the TNF alpha, the high sensitivity C-reactive protein. They've been writing about that locally and its effect on endothelial health for a long time that the cardiology specialty has recognized. But now it's really looking even further at where is the upstream problem, and it has to do with breathing and sleep. So I'm very excited when that comes out.
Super
So
cool.
all
Yeah.
we're saying is that the role of the dentist is really moving beyond the immediate structure that we're looking at and looking upstream
Yep.
to maybe the root cause. And it's really putting going beyond putting your nose under the tent. It's actually completely unveiling the wizard that's behind the wall and say, I know the Wizard of Oz is this small little guy. We'd have a role in really dealing with and talking to our patients about this. Moreover, the public at large is very frustrated with a pharmaceutically driven disease management healthcare system where the stakeholders in pharmaceutical device industry is getting rich, but our population is getting sicker. And people are trying to take more control of their health. And a night guard is not going to really address the damage to the teeth if you don't really understand, the root cause as an example, and temporomandibular disorders, and all these things that now puts a dental provider in the driver's seat in working with the medical counterpart to a tangible benefit to the patient, a tangible outcome, because the patient is central in Airway. They are the most important member of our team.
Yep.
And in the traditional approach, they're just kind of like there. They don't really have much of a say. And that's changing because now in medicine, it's all about outcome measures and accountability in outcomes. So if you're not successful, you're on the hook to make sure you are and redo whatever it is that you did. And I think that's smart. And so I think 2026 is definitely going to move in that direction. And I predict, Richard, that you, Barry, and I are going to play a central role in this. I know I'm going out on a limb on this,
Mm.
but that we really will help. And we're doing this not because of our ego and because we need this. It's because we see that we want to improve the role of the dentist in healthcare beyond a mechanic. And look, we can retire. You, me, and Barry can retire. We don't need this. But I think we're boomers. We have this sense of responsibility that goes beyond work-life balance,
True.
that we're not committed
What is
to.
that? Work-life balance.
Yeah, I mean, you don't go in, honestly, you don't go into healthcare in any capacity in looking for work-life balance. It's just not, if you want that, become a banker. Maybe you can become an attorney. Maybe you can, but really we're committed beyond ourselves by the Hippocratic oath to our patients. And it's what makes it a noble profession. And your family understands that and respects that, hopefully, at this point.
Absolutely.
It, so
That's great. Yeah, I'm really, I'm a little, I guess, excited slash apprehensive a little bit because when the dam is going to break, Mark, and uh,
we're prepared. We're
yeah,
prepared we've been
we're
planning.
ready. But I mean, it's what in the world is going to happen? And with new information comes all kinds of good things and bad things, and so we're going to see stuff pop up that still misses the mark. We're going to see people that intellectual property will be stolen and recycled, and a lot of this stuff happens, and it's very uncomfortable to me. But at the same, you just got to stay above the fray and keep doing what we're doing and helping people. I was just thinking, while you were talking about your perio chapter, that the periodontists in many respects are really they're sort of the internal medicine leaders of our profession of dentistry, and they're highly credible, highly credible. In the dental school environment, the periodontists carry with them, this agency that is quite stellar and almost unquestioned by anybody. And students learn really early how important perio is. And so once the periodontal especially gets a hold of this chapter, for example, and starts teaching this in dental schools, it's going. I can't even imagine how enormous that impact will be. Other than the fact that it's going to be as big as I think it's going to be as large as anything that's ever happened in dentistry. You
Yeah,
know.
I think, and I write about this in the first chapter of the Airway textbook,
Mm-hmm.
is that I've always been fighting this in the background. I've always been concerned for those that we teach airway concepts to, is that you need to be prepared to defend what you're doing with a data science driven approach.
Yep.
And so I know that with the referencing, I know it's in good stead. Um, and in the perio, it's just we're looking at an area that was never looked at before,
Right.
right? So,
Right.
but the references are there,
Yep.
and it's not new information that I've made up. It's just the way I've organized it in a way that it's just asking the question. And so what we know is that it creates, as Thomas Kuhn talked about, scientific revolution. And we've seen this from the beginning of time. Um, well, not beginning of time, but from the beginning of civilization, we've seen the Copernicus and Galileo challenging the orthodox thinking that was super disruptive. Galileo got exiled. He was thrown out because he was saying that the Earth was not the center of the universe,
Sure.
right? And then,
Right.
of course, you could see Florence Nightingale that talked to the surgeons about cross infection, and she used statistics to show that.
Mm-hmm.
And Ivar Semmelweis talked about hand washing, and these people were excoriated initially, and then afterward it became a standard. It's kind of one of those things as well, is what I have found of things that I've talked about for a long time, that all of a sudden, all of a sudden, the people who were saying there's not enough evidence now are the experts, right? And they just
Yeah.
have partial knowledge.
Yeah. I
It's
I
okay.
was it's so funny because I don't remember exactly when it happened, but I was kind of digging into Airway, and your name came up, and Chat GTP said Dr. Mark Cruz, known for being at least 10 years ahead of
Oh, did it say
everybody
that?
else. It actually said that on Chat GTP. I was
Wow.
like, wow, awesome.
Gosh,
But
I didn't know that. It's interesting because I get a lot of patients now, and it concerns me, through AI. But I don't. It's not that I want any of this. It's just that we need to make it about the dentist.
right,
We need to scale so that people understand that airway is not palatal expansion. It's not the same thing.
of
Y-
course.
Right? And
Yeah.
I think we, going back to Dr. Tucker, who's also my mentor, one of the things that I learned from him is that sense of humility, to be open to new ideas, to always question, but trust. And then you learn in practice. And that's what happens with Airway is there are some complicated concepts, but then when you start implementing it, you see something that you didn't see before, and now you can't unsee it. And it really changes. And so we want to build a community that we always go back and grow from this.
Yeah.
We know it's incomplete. We know that there's a lot more to do, and we want people to replace us and to take at when we're long after we're gone,
Yep.
that at least, we could say that it was maybe that flint that started the fire, and that um, we will not be remembered, who cares, but that it's really helped the public's health, that we need
Beautiful.
to
Yep.
really change an unsustainable problem in healthcare disease management, that we improve quality of life, decrease um, autism and ADD, ADHD, decrease overtreatment. Okay, with that said, what was your learning moment this week? And then we'll close up.
It was kind of a funny one, but I was my wife and I were watching a series called Victoria, which is all about Queen Victoria, and she became Queen of England at a very young age in 1837, and she reigned. She was the longest reigning monarch in the Great Britain's history until Queen Elizabeth II. Anyway, the actress who plays Victoria in the show is stunning, absolutely by anyone's standards, quite lovely, beautiful in all respects. And I was looking very carefully at her profile throughout the series, which you can see many times, and it's the ideal profile. It's just high cheekbones, full maxilla,
Came from central
nose.
casting.
Yeah, yeah, full max. Everything's there. But when you go back, because I have an interest in history, I look at the coins of the monarchs of the UK, of Great Britain, are telling because they're all profiles, right? And so you see all the monarchs on a profile facing right or facing left. They alternate each new monarch. They do east west. And so when you look at Victoria on all of those coins, she's retrognathic. I mean, and her indicator line is probably 46 or something. So, I'm looking at that.
Bimaxillary
I'm like,
retrusive.
oh my gosh, Hollywood could not find an actress. They could, but they wouldn't, because they need to present this
Visually appealing face.
right. I thought that was so fascinating. And so it got me to dig into all the monarchs of the UK. And it's like, oh my gosh, there's so many of them had going way back, back to the 1600s, where they were, obviously industrialization of the monarchies had changed. They were eating soft food and being pampered, and were not being out in the fields doing the things that the the less fortunate had to do. So it's just kind of interesting, and it's just you see it everywhere. I guess like you said, Mark. Once you see it, you can't unsee it, and then you become a wiser clinician, a wiser uh, mm, assessor, a diagnostician of your patients. So that was my take-home message.
Yeah, interesting, Rich, that you found that. Again, you would have never seen that before. You've been collecting coins, and it gives a hint of one of the principles that we talk about in the Airway Mini Residency, which is understanding the anthropologic standard. We
Yeah,
want to treat our patients to aesthetically, form follows function, look more like the actress that has a straight profile that's
right,
not really representative of the actual person that the movie's about.
right.
But I think that if you were to look at a coin, if in a museum that had Caesar's profile, I think you probably see Caesar would probably have a straight profile.
Yeah,
Certainly, if you look at the Indian coins, you could see that there is a straight profile, a
right.
more straight profile uh,
Absolutely.
on all those. And again, it's kind of hidden in plain sight. We see George Washington, who was edentulated, and you look at his profile and how much it's melted back because of all that. But interesting, and
Absolutely.
it also central to Airway. But I thought that's thanks for sharing it.
No,
That's
you're
great.
welcome. It was fun. It was fun.
Yeah, well, I look forward to our next
So do I,
this
Mark.
next year, 2026, and to our next podcast, and look forward to in 2 weeks. I think is it 2 or 3 weeks?
Yeah, let me look up at my
Let
calendar
people
here.
know.
Remind myself that is January 16, 17, 18, 2026 for our Phase 1 AMR 3.0 here at
Friday,
our
Saturday, Sunday.
center. Pardon
Yeah,
me?
Friday, Saturday, Sunday. So it makes
Yeah,
it pretty
yeah, Friday,
straightforward.
Saturday, Sunday, and San Dimas, California. So,
Good. Well,
see
hopefully
ya.
we'll see you all there. Rich, have a great rest of your day and we'll talk
You too,
soon.
brother.
All right.
Okay.
You're very
Thanks.
welcome. Thank you.
Bye.
Bye.